Okay, sacroiliac joint tests. The lectures we've done this morning, we've talked a lot about how the standalone tests, and particularly the palpation and the motion tests, have not demonstrated any real reliability or any real validity. And this is one of the cases where it actually fits very well with my clinical experience. I found there's a lot of tests out there that really don't tell you a whole lot, or have the potential to tell you so much that it's really difficult to work through it. And what some of the research has shown now, Laslett in 2003 and 2005, and Van der Werf in 2006, and Kochmeyer in 2002, and one of the others is Stuber in 2007, have all started to focus on the concept of a cluster of tests now, which in some ways have individually proven to be very sensitive and very specific. But as a group, they're about 85 to 90% predictive in some cases of patients who have sacroiliac joint pain or dysfunction. They've also been proven to be very good effective rule-outs as tests. Given that if they're negative, then we can be pretty sure that the patient does not have any SI joint dysfunction, which of course leaves us free to look at the hip and the lumbar spine. These tests have all been tested against the gold standard of SI joint assessment, which is the SI joint anesthetic block, which effectively rules out pain or dysfunction by either taking pain away or by not doing anything, in which case there's obviously no SI pain. So the first test we'll do is I'm going to have Travis just rest his hands up on his chest to keep them out of the way of the test. And this is a compression test for the SI joint. The heels of the hands will come to the inside of the anterior superior iliac spines. My forearms will come down as close to parallel as possible. The force that will be supplied is this way and this way, in an effect to compress those joints at the posterior superior iliac spine. And we're looking for reproduction of pain, which we can get either from facial expression or from a verbal response from the patient. And very small force to start, and then build up to a stronger force as you hold the position for about 7 seconds, and then relax. The key with that test is to ensure that you're in a position that's comfortable. This is a very tender area. The ASIS area it is also quite tender, and it's difficult to ensure that we get a place where the patient's not painful. If you get a painful spot, that's going to give you some problems with your testing because you don't know if you're getting the right positive or not. The second test is the posterior shear test. And this test will be done by standing on the patient's painful side, hip flex to about 90 degrees, adduct and rotate so you can get your hand under to the PSIS region and palpate the interspace at the PSIS and the sacrum. And then going to work around a little bit just to find the place where I feel that the joint is gapping maximally. Now, of course, the patient's got to have pretty good knee flexion here. If they can't get full knee flexion, one of the options you have is to just do this. It's not quite as effective, but you have got that option if you need it. So I'm in roughly 90 degrees of knee flexion. I'm in slight adduction. I'm going to produce a thrust movement, not a quick movement, just a strong downward force. I'm going to feel for gapping or pain at the SI joint. And this is one where I really do feel like you can feel some sponginess or feel some gapping. And you can feel also for a stability issue if it is a little sloppy at end range, or there should be just a nice hard end block. And you can slightly increase or decrease your movements just to get a sense for the joint in slightly different positions. That's where it feels most stable to me. If you do get one that feels a little bit sloppy or a little bit loose, what you can then do is find the position where you found that, and then ask the patient just to draw in their abdominal muscles. And then retest. And what you'll find, if it is a stability issue, often it will get better when the patient brings in the abdominals. We know that the transversus abdominis in particular has been shown to increase forced closure at the SI joint and compress that joint, which will decrease any of the passive stability. So that is a good mechanism to give us an idea of some sort of prognosis if we go on and do a stabilization program segmentally in the future. The third test that we'll do is Gainsland's test. And this is a test whereby we have the patient bend both knees up maximally, and they'll hold the contralateral knee by placing the hands just underneath there, yeah? No, just on that one, yeah. And then we will straighten out the other one, and we're looking to make sure that the leg actually is able to flatten out completely on the table without getting into pain or dysfunction on that side. This is sort of similar to the Thomas test, which we can also do by, if we just have Travis completely relax and move across to the side. Good. And then we can repeat the movement here. Okay, and we'll straighten, and this time, if we've got a normal test on the previous occasion, the leg can come off the side of the table. This will allow us to check the length of the iliopsoas, to some extent the rectus femoris, and also to some extent the lateral muscles of the hip to see if we've got any tightness. It'll also make sure that we've got full anterior rotation of the hip on that side. It's a relatively good test. I find this to be much more useful for muscle length testing. It can also be done off the end of the table, just being careful to make sure that you have a table that won't flip. But I find this much better as a muscle imbalance test rather than a joint-specific test. Next test we'll do is in side lying with the patient facing away from me and you standing behind the patient, either behind their buttocks or just somewhere behind the lumbar spine itself. I prefer to stand just behind the lumbar spine. Ideally, you'd have the patient a little lower here than is normally the case, but you can also compensate by standing on tiptoes. The heel of the hand in this case is going to find the iliac crest anteriorly, making sure the patient is in perfect side-lying neutral, and then you'll just lean down and sense a gapping or a distraction posteriorly. This is definitely a pain provocation test, and Laslet's study in 2006 found this to be one of the most sensitive and predictive tests for pain. If that test is painful and or the compression test is painful, you can be pretty sure that you do have an SI problem, and it's not always necessary to perform the other tests. The last test will be done in prone. And again, ideally we'd use the face hole. Just the patient will develop a comfortable position somewhere by then. I'll then actually just have them lower the hands off the side and the arms. This really relaxes the scapula and takes all the other fascia out of it. And this is the sacrum. So what we're doing is just getting our heel of our hand on the lateral edge of the sacrum. I'm going to use my other hand on the other PSIS so that we get a good stabilizing force. And then the heel of my right hand in this case will be pushing laterally. And this is a shear test in the opposite manner to what we did in supine of the sacrum at the posterior sacroiliac joint. We're looking for stiffness, we're looking for a slightly sloppy feeling, or we're looking for reproduction of pain. And this is a very good way of testing the stability of that joint. You again can have the patient bring in a transversus abdominis contraction in a positive test, and that will allow you to get a very good sense of exactly what's going on at that joint. Those 5 tests together have been proven to be very reliable and valid and predictive of SI joint problems. And hopefully over time we'll be able to match up some treatments to these tests in order to make them even more valid.